We are going to get started.
Yeah.
So Dr. Connors, I'm just going to go through the introduction and then we'll let you share your slides.
Okay. I don't know where my brain's at this morning, but thank you.
Thank you. Not a problem. So hi, everyone. Welcome to another edition of the CanVector National Thrombosis Seminars. A reminder that these seminars are hosted throughout the academic year, and we discuss state-of-the-art thrombosis and VTE lectures presented by Canadian and international experts. I'm Camille Simard. I'm an internist and thrombosis physician in Montreal. I will be your moderator today. The video recordings of the seminars are on the CanVector websites. And just as a reminder, this is a self-approved learning activity in Section 1 for CME for the Royal College. This is our planning committee, and our chair is Dr. Tsu-Fei Wan. So I'm going to introduce our speaker today. So it's really our pleasure to have Dr. Connors today speak about transgender health and VTE. Dr. Connors is a hematology attending at the Brigham and Women's Hospital and Dana-Farber Cancer Institute, the medical director of anticoagulation management services and the hemostatic antithrombotic stewardship program. And she is an associate professor of medicine at Harvard Medical School. She received a medical degree from Johns Hopkins University in Baltimore, completed her residency in internal medicine at Beth Israel Deaconess Medical Center in Boston, as well as fellowships in transfusion medicine and hematology and oncology from Brigham and Women's Hospital. Dr. Connors is an associate editor for the Journal of Thrombosis and Hemostasis and is a member of or holds a leadership role in many professional societies. She has participated in numerous clinical trials for patients with venous thrombosis, and she is currently the PI for an NIH antithrombotics trial in COVID-19 positive outpatients. Dr. Connors, we are so happy to have you present today. And with that, I will let you start your presentation.
Thank you so much, Camille. And I apologize to everyone for thinking we were getting started an hour later, despite all the times being correct in my calendar. So thank you for your patience. And if there are many questions, I'm more than happy to stay over time. So I'm going to share my slides. I'm going to go to presenter mode, and I'm going to talk about transgender hormone use and VTE risk in clinical practice. The cases that I'm going to show are cases that were actually referred to me. So these are real bona fide cases. And I've used these cases a number of times over the last few years because they represent the big questions that we have in treating our transgender patients when we are a consulting hematologist, vascular medicine clinician, or expert in coagulation, and we get referred these patients to us by our endocrinology colleagues. So, and I had a COI slide, but not sure where it went. And so let me just back up for a second and make sure that we have the correct. Yes. Okay. So there are far more patients in the world that identify as transgender than we have been previously aware. Approximately 25 million people around the world identify as transgender. Now, transgender patients have incongruence between their gender identity and the sex they were born with or assigned at birth. The transgender is not sexual orientation, and this sometimes gets confused by the lay press and lay people, but not practitioners. And in this presentation, I will focus on binary designation of sex, male or female. There are many people who have non-binary gender identities, and those patients or people will not be discussed today. As I alluded to, coagulation specialists need to know the medical aspects of transgender care and be able to deliver that care with respect. I have encountered, as have others around the world, patients that do not disclose symptoms or sometimes do not disclose treatments, particularly hormonal treatments, to physicians because they are concerned about the response that they're going to get from clinicians. Now, this is a busy slide, but this is a public survey that was performed in the United States and published in June 2020. 1,500 self-identified LGBTQ persons in the United States were surveyed and responded. And the graph on the table on the left, I used to show you that of the sample demographic populations, those that identified as transgender avoided doctors' offices 47% of the time because they were concerned about discrimination and lack of understanding of their specific needs. When you look at the graph on the left-hand side, from the same study, you can see the barriers to accessing healthcare that are perceived by transgender Americans. Everything ranging from doctor was visibly uncomfortable at the top here, somewhere between 30 and 50%. That was also affected by race, but down to physicians refusing to see patients in over 10% of the time. In some situations, if you read the fine print in this manuscript, you find that the patients themselves actually have to inform the clinicians about their specific treatment needs and types of treatments and procedures. Now, terminology has undergone some evolution in the last even 5 to 6 years. And I use this glossary to convey the correct terms that are currently in use so that people can precisely communicate. The slide deck that I'm using is available and it can be distributed if you're interested in obtaining it. Gender identity is a person's inner sense of being a man, woman, something else. Some people identify as I said, non-binary or no gender. Sex assigned at birth is now no longer called biological sex. It is assigned female at birth, AFAB, or assigned male at birth. Transgender and gender diverse are people whose gender identity differs from what is typically associated with their sex designated or assigned at birth. This is the opposite of cisgender. Cisgender are congruent with sex assigned at birth. Gender incongruence now has ICD-11 terms, and it is now in gender incongruence as opposed to transsexualism, which was the term from over a decade ago, or gender dysphoria. The male to female designation or female to male are no longer used. Patients who've transitioned are referred to either as trans women or with trans feminine adjective or trans man. And as I alluded to, non-binary are people who fall outside of this traditional male, female, or man-woman designation. So the first case is a patient I saw a few years ago who was a 44-year-old trans woman who had used a contraceptive formulation listed here that was actually not available in the United States. And this was a patient I saw probably over a decade ago now. And I actually was not familiar with this parenteral birth control that was administered as a once-a-month injection. This patient had been using this combination estrogen progesterone injectable contraceptive without a prescription for over 16 years, but had stopped after breast construction surgery, thinking that the hormones were not needed. However, she now wanted to restart hormone therapy for a variety of the positive benefits associated with hormonal therapy. But she was referred this time by an endocrinologist with whom she had established care, as her younger brother was recently diagnosed with a VTE after a car accident. And as a hematologist, I was asked, does this patient require thrombophilia testing? And is it safe for her to take estrogen? So hormonal therapy in transgender patients is used to achieve secondary sex characteristics. Hormone therapy is usually continued indefinitely, even if gender-affirming surgery is performed. And in this case, the patient missed a lot of the subtle secondary sex characteristics associated with hormone use, but also the mood regulation and other aspects that were positive effects of hormone therapy. The goals of therapy in trans women are to achieve female levels of estrogen and suppress testosterone into the physiologic female range using the lowest doses of hormones possible. I'm going to show this slide at the end because this is key. It's normal physiologic levels. Often I tell people, particularly for trans men, to aim at the lower limit of the normal range. We're not looking for super high levels, and we do not have to achieve high levels in these patients to get desired effects. In trans men, we want to maintain after achieving physiologic male levels of testosterone. And as I said, the lower we believe is the better, although the data to support that are clearly not there. In trans women, we use estrogen to develop female characteristics. Estradiol or oral or transdermal estrogen is associated with the lowest VTE risk, and I will show you that data in a few minutes. The hazard ratio for thrombosis is a little bit higher in trans women than in cis men. And a little bit higher in trans women than in cis women, with HRs of 1.5 for compared to cis men and 1.7 compared to cis women. We advise, and I think this is no longer practiced anywhere except in countries where there may be difficulty obtaining any estrogen formulations or the wide range of formulations that we have in first world countries, is to avoid ethinyl estradiol because this is associated with an increase in VTE, even in cis women. And it is the hormone replacement therapy dose of transdermal patch that I'm going to discuss, and not the contraceptive patch. The VTE risk with estradiol may continue to increase over time in trans women compared to the postmenopausal cis women, in whom the risk increases in the first couple of months of use, but by after 1 year of use is no longer a factor. Now, I'm sorry, I'm actually going to stop sharing for a minute because these are not ordered appropriately. So again, sorry for the timeout here. We have a problem with version creep. And so I am going to reshare my slides here. And make sure that we're looking at the right version. Yep. And I again apologize. So we're going to march through this because there's a little bit of a different organization here. So these are the keys for trans women transition, which I've already discussed. Estrogen is used to develop female characteristics, but we also need to suppress testosterone in most cases for hormonal therapy in trans women. Now, the combination oral contraceptive effects on coagulation factors are known in cis women to increase the prothrombotic factors such as fibrinogen, VWF, factor 8, factor 7, 10, and prothrombin. But this is also accompanied by a decrease in the natural anticoagulant factors such as protein S. Patients develop an acquired resistance to activated protein C due to the high levels of factor 8 in response and the drop in protein S. So these are known in cis women. These also occur in trans women as well. And we can see from this analysis using not oral contraceptives, but postmenopausal cis women using oral estrogen and transdermal estrogen. The slide I first showed you a few minutes ago before switching presentations was the differences in thrombin generation between oral and transdermal hormone replacement dose estrogen in postmenopausal women. And so you can see the endogenous thrombin potential here, and the total thrombin potential, and differences in the peak and the lag time. The first category of patients in these graphs are those postmenopausal women that are controls, no hormone replacement. And then we have the oral hormone replacement measurement and the transdermal hormonal replacement therapy. And you can see it at all of these values obtained when doing thrombin generation assays, particularly the endogenous thrombin potential, that those treated patients taking transdermal hormonal replacement therapy have very similar responses to those the controls. And so there is higher endogenous or total thrombin potential in those taking the oral, with those using transdermal formulation much closer to the controls, although you can see in some areas that there is a small amount of difference. It's not statistically significant. In another similar study by Luke Sheras, just published 3 years ago, we see a different assessment of factors, looking at factor levels instead of thrombin generation. And we look at oral estradiol on the far left, trans women taking transdermal estradiol, and all summed in the last graph on the right. And these patients had baseline values and then were assessed for change from baseline after 12 months of gender-affirming hormonal therapy. About half were on oral estradiol and about half on transdermal estradiol, and 90% were also on anti-androgen therapy. I'm not going to walk through all of these individual factors that include the activated protein C ratio, factor 2, 9, 11, fibrinogen, hematocrit, protein S, and protein C levels. The green represents an anticoagulant shift, so a more pro-anticoagulant profile. Pro-anticoagulant, that's like a double negative there almost. And the red dots are an increase in procoagulant factors. And when you sum all of these up and you look at the final results, you can see that for the most part, as represented here, the overall result leads to a procoagulant change in these women, with subtle differences between transdermal and oral estradiol. So the estrogen and the VTE risk, as I showed you in the first presentation set of slides, is that ethinyl estradiol has the highest risk associated with thrombosis, and this is dose dependent. So if you have no other hormonal agents available and ethinyl estradiol is it, without combination with a progestin agent, the lower the dose, the better. What we have learned is that oral estradiol, the parenteral estradiol preparation and injectable, and the transdermal estradiol are very low and very low with regard to thrombotic risk. And these are the agents that we should use in our transgender patients. Now, suppression of testosterone is also important because this minimizes any male secondary sex characteristics. Spironolactone has been shown to have no associated VTE risk. Cyproterone acetate, which is not available in the United States or Japan, is maybe associated or is associated with a slight increase in VTE risk, but based on recent studies, including the study here over on the right-hand side, using CPA at a lower dose than previously used. It used to be a standard to give 100 milligrams. You can now see that even 25 milligrams and 10 in most, 10 suppresses testosterone below the lower limit of the physiologic range, when therefore is associated with lower VTE events. We do not use in adults, and I should have prefaced this presentation by discussing adults. I have a few slides with information for young adults and adolescents at the end, but GnRH agonists or antagonists are not typically used in adults. So this slide you've seen, when you sum all the data, there is a slight increase in risk of VTE using oral or transdermal forms of estrogen in trans women. It's 1.5, as I said, and this is again loose and based on limited data compared with cis men, and 1.7 compared with cis women. There are no really great randomized trials at all. So even the data I just showed you about endogenous thrombin potential is based on people and their practitioners selecting type of estrogen therapy. Again, I cannot say this more than once, avoid ethinyl estradiol, and it is the hormone replacement therapy dose. And the risk may continue over their lifetime of use, unlike in postmenopausal women. So with this first patient, I discussed this slight to minimal increased risk associated with transdermal HRT dose estrogen compared to cis women. We talked about using spironolactone to suppress testosterone with no increased risk of VTE. I counseled on lifestyle risks to avoid, such as obesity, smoking, and suggested, this patient pay attention to the typical cardiovascular risk factors with aging, as the patient was 44 years old, such as lipid profile and hypertension. We did discuss there's no need for thrombophilia testing of this patient. They had 16 years of combination contraceptive use with no thrombotic event up through age 42, and the brother's event was caused by a strong provoking factor. So one other question that comes up frequently, and we see this a lot in trans women who've been started on estrogen or are starting, they themselves have a history of VTE, or they've developed a VTE and are seen particularly in emergency departments where they are told to stop estrogen supplementation after development of VTE. Hormone therapy in transgender patients, particularly trans women, is associated with improved quality of life for many reasons that I'm not going to discuss here. So the lower risks with the oral or transdermal estrogen therapy and testosterone suppression are acceptable to many patients. Many patients will take that 1.5 HR or even 1.7, although the 1.5 applies to trans women, even if they have a history of VTE. So hormonal therapy can and should be accompanied by continued use of anticoagulation if the patient experiences a VTE event after initiating hormonal therapy, or even if they have a history prior to hormonal therapy. Long-term anticoagulation for secondary VTE prevention can be managed by skipping doses to allow participation in contact sports, like I practice in my cis-gendered patients, and at other times of increased bleeding risk. Now, the data for cis women with VTE on oral contraceptives show no increase in recurrent VTE while on anticoagulation. And this comes from the rivaroxaban, the Einstein, PE, and DVT trials, that women who continued oral contraceptives, which are a much more prothrombotic agent, had no increase in recurrence. The strategy for using low-dose 10A inhibitors, as it was studied in Amplify Extension and Einstein Choice, have not been reported for transgender patients. But if there are no contraindications or concern for plasma levels, using this strategy should be okay. And I do use this strategy. I assess weight and look for the drug-drug interactions that patients may have or absorption concerns. But otherwise, the Amplify extension of Pixaban 2.5 milligrams twice daily or rivaroxaban 10 milligrams once a day strategies can be used in these patients as long as they are aware that there are no data, particularly in trans women, and we call this shared decision-making. Case number 2 is that of a 23-year-old trans man referred for evaluation of thrombotic risk. He had been using testosterone gel prescribed by his endocrinologist for 2 years. He actually happened to be a biochemistry PhD graduate student at my university. However, what prompted the referral was that his 71-year-old grandfather had just been diagnosed with a pulmonary embolus, and this prompted a visit to the PCP and anxiety about hormonal therapy, which led to our visit. The patient's father, sister, who was age 19, and brother, age 25, had had no VTE history. And so when trans men are transitioning, we use testosterone to suppress female sex characteristics. So again, we take data from cis men or cis women and look at risks and then try to apply them to transgender patients. This was a study published in 2016 looking at older men with physiologically low, below the lower limit of normal testosterone levels, and treated to the mid-physiologic range for 1 year and looked at adverse events. And so although this study of close to just over 800 participants was underpowered to detect differences in adverse events, there were numerically reassuring results. And so you can see that there was really no difference in prostate cancer in this population, which does not apply to our patient population. But we should remember that depending on whether or not patient has had surgeries, transgender patients, trans women and trans men are at risk for cancers in the organs that they were born with if they are not surgically removed. So what's reassuring is that the cardiovascular events in these populations were not different. There was no difference in number of strokes. There was no difference in MI, and the rates were reassuringly low. And SAEs did not vary either. And Luke Sheres and colleagues did the same assays that they did in trans women, in trans men, looking at change in baseline coagulation factor levels at baseline and then after 12 months of gender affirming hormonal therapy, and looked at the 2 different types that are available: intramuscular IM testosterone preparations and transdermal testosterone, which many patients use today, whether they are cis men or trans men, as an androgen gel formulation. And as you can see, if you spent the time to look at all the factor levels, and again, red dots indicate a procoagulant change and green squares indicate a more favorable increase in natural anticoagulants, that overall, if you summed these, you would see that there's minimal change in procoagulant factors and that there are beneficial changes in natural anticoagulants. And so overall, the risk is felt to not be significant. Many have looked at the effect of testosterone on hemoglobin and hematocrit in trans men, including Joe Schatzel at Oregon Health Sciences University. And in these 519 patients with pre and post hemoglobin and hematocrit values pre-starting testosterone suppression versus post, you can see that the mean peak hemoglobin was 15.7 and hematocrit 47%, which in our lab falls within the normal range. Interestingly, the mean time to peak was actually 31 months, which was, a lot longer than you would have expected. Very few developed VTE, including 2 superficial vein thromboses, 2 calf vein DVTs, and 1 stroke. And so you can see that there is an expected change in hemoglobin level associated with, did I say suppression? Associated with the use of testosterone in trans men, but we expect this. And you can see that both the hematocrit and hemoglobin track as you would expect. Now, this is a different study from a different group, Madsden and colleagues, and you can see that there is this sort of prolonged increase, but it is subtle over time, and that it's really within the first year that we see the biggest increment in hematocrit. In this study, they had over 1,000 trans men followed for up to 20 years. What is very interesting, and maybe a factor out here at 20 years, is that age at initiation of use may affect the hematocrit, but also smoking, increased BMI, and pulmonary disease. So for trans men transitioning, testosterone is used to develop male characteristics. There is no increased VTE risk that's been conclusively demonstrated at all. There's no increased risk of MI or stroke, and I'll show some of that data. And the increase in hemoglobin and hematocrit is expected. Now, as an aside, I see cis men who are older who have low testosterone levels who are started on testosterone supplementation. And if they're not monitored and the dose is too much and their testosterone goes above supraphysiologic ranges, we can absolutely see a concomitant increase in hemoglobin and hematocrit above what we expect. And so I have seen some pretty high hemoglobins in patients who were not monitored. So this is why the recurring theme of using physiologic, monitoring to assess the level of supplementation and making sure that you're targeting the low physiologic range based on desired side effects, but also hematocrit and hemoglobin level. So we suggest decreasing the testosterone dose if possible and changing other lifestyle factors if you do see an increase in red cell mass. As an aside, increased red cell mass in any patient is associated with an increase in blood pressure, so you need to monitor blood pressure. So patient in case 2 was reassured that there was no associated increased risk of VTE. We did discuss, despite the age of 23, of lifestyle risks for VTE and cardiovascular risks over time as he aged. We checked the hematocrit and it was 48%, which was in the normal range at our lab. Patient was very happy. Data are observational and less less data available in adolescents and young adults. And so Dr. Mullins, a colleague of mine, did a retrospective review of 611 adolescents and young adults that initiated gender-affirming hormone therapy with a median age of 17 years. 28% were transgender women or trans women, 68% were trans men, and some used hormones but were non-binary in their review. These patients did have thrombotic risks that were independent of hormonal use, including obesity or morbid obesity in a large proportion, tobacco use, family history of thrombosis in 8%. And 3 of these 611 individuals had a history of VTE, including or thrombosis, including 1 stroke. 182 of the 611, or 30%, initiated estradiol with a median dose of 4 milligrams and a median follow-up of about 1.5 years, although it was a very long follow-up period from the database at their institution. 70% initiated testosterone, as would be expected with a higher proportion of trans men. 5 patients were started on thromboprophylaxis at the time of gender-affirming hormone therapy initiation. And this included the 2 patients with prior VTE and 3 patients with family history and other personal risk factors. None of their patients in their database developed thrombosis. So again, we know that age is a factor for VTE, and it's your older patients that may be at risk. I've seen patients in their 60s, trans women who've stopped hormone therapy for a few years and want to reinitiate, and they're 62, 63 years old. And I counsel about the risk just based on age alone. And so the last few slides are more about the cardiovascular complications and how we can look at the data that we currently have. And this is just from a cardiology journal written by cardiologists about gender-affirming hormone therapy in transgender adults. And it's a good review of data that are out there that was published in 2019. But this shows you all of the factors that go into vascular disease, including inflammation and dyslipidemia, as well as natal sex atheroma burden. So lots of factors besides hormone use in these patients. And this, again, I think does a great job depicting the differences and effects of estradiol versus testosterone on vascular smooth muscle, endothelium, and myocardial cells. And so I'm more than happy to share my slides with you so that you can review this in detail. So this is a study that many people quote that was published in Circulation in 2019, and it looks at adverse cardiovascular events associated with hormonal therapy. The factors, and the reason I show this incredibly busy slide is because I want to point out that this is an EHR database analysis, starting with patients entered into the database in 1972. Well before statins, well before we had really good hypertension control, before smoking cessation campaigns were started. And so as I note at the bottom, there are multiple confounders or in this that cannot easily be accounted for, including the type and dose of hormonal therapy. You know, in the 1970s, combination oral contraceptives were really starting to take hold in cis women, and much higher doses of estrogen were used at that time. So I mention that because it is important to keep that in mind, and that the risks were noted by the authors for these cardiovascular events were found to decrease over the time period study. Basically, there were 2,500 trans women and just about 1,358 trans men in this population. And you can see that there is an increased risk if you look at the standardized incidence ratio in the red box here for VTE in trans women compared to cis women. And some increase in stroke and MI, but again, the confounders need to be accounted for. And the difference is if you actually compare trans women to cis men, the risk for MI is actually lower, and the risk for stroke not significantly higher, but the risk for VTE persists. Trans men, again, lower risks when you look at differences in the baseline reference populations. Again, MI appears to be higher in trans men, but the smoking confounder needs to be accounted for. If we look at this same review by Paul Conley in Circulation that has those nice graphics, they've tried to summarize the effects of gender affirming hormonal therapy on the vascular health of transgender men and women. And you can see here that there are minimal changes in transgender males with hypertension, possibly due to increased in red cell mass, and interestingly, lowering of lipids, but maybe more pronounced ischemic heart disease and cerebrovascular disease over time. And this is why monitoring the whole patient and not just for us, it's going to be VTE risk and thrombotic risk, stroke, but the entire cardiovascular health assessment needs to be performed. Again, a similar paper looking at mortality trends over 50 years again in adults receiving hormonal treatment in Amsterdam. And you can see that the standardized mortality ratios do appear to be a little bit higher in transgender women. But again, we need to look at the confounders in these data. So my last few slides, assess standard VTE and cardiovascular risk. And even as a hematologist, I will make sure that patients monitor through their PCP or endocrinologist their lipid profile and always comment on smoking. Obesity, I just want to point out that, the odds ratio for VTE with increased BMI is 2.4. But if you add combination oral contraceptives to that, it's synergistic, and that we don't have the same data for the hormone replacement therapy doses, the low doses of transdermal or oral estradiol. I think it's not nearly as significant, but we use COCs in obese women all the time without as much assessment as we give to our transgender patients. Personal and family history, VTE, lipid profile, diabetes, hypertension, all the cardiovascular risks. An individual risk assessment profile needs to be considered in any patient. One question I get asked frequently is about the association of surgical risk with exogenous hormone use and what should we do with hormones at the time of surgery. This question also comes up in our cancer patient population who may be on hormone suppressive therapy, such as women with breast cancer. And the data, if you read through this, are unclear because the evidence is inconsistent and there are not a lot of data. So I'm happy to answer questions about how we address this, but there are not enough data to make even a guidance document about how to manage particularly the estrogen risk around surgery. The North American Thrombosis Forum has put together with some of my colleagues here from Brigham and Women's Hospital, including Nathan Cannell, Devin Kuhn, and others, with a transgender health and blood clot risk patient toolkit, which you can download from their site. They say in their manuscript that there are no existing VTE risk scores that have considered hormonal therapy. And so risk assessment is hard to do in these patients. And we know that gender affirming surgeries present unique perioperative concerns. So hormone therapy in transgender patients is used to achieve secondary sex characteristics. It is usually continued indefinitely, even if gender affirming surgery is performed. The goals of therapy, as I've said now, I believe 3 or 4 times, are to achieve physiologic ranges. using lowest doses of hormone possible. There are limited data regarding the hormone effects in transgender patients. We take cisgender results and apply them to transgender patients, but you can see that there are some differences, and particularly even, which population do we use as baseline reference? We need more specific data on both short-term and long-term risks, but we have to keep in mind that the values and goals of hormone therapy differ in transgender patients. So I see many patients who have inherited thrombophilia. They may be in their 20s. They may have had a VTE. I discuss, you cannot use combination oral contraceptives. I strongly advise against it, is probably a better way to phrase it. But these cis women have other alternatives for contraception. For transgender patients, there are no alternatives to the hormone formulations that we currently use. And so we work with our patients to effectively and safely use these treatments as best we can. Stopping therapy in transgender patients is not acceptable in most cases, and these patients are willing to accept the increased thrombotic risk or use of concomitant anticoagulation to prevent thrombosis. It takes a multidisciplinary team to care for transgender patients. We need to have cultural competency, respect, and sensitivity. But we have to be knowledgeable about the treatments and what the treatments entail. We need to understand differences in goals of therapy. And of course, as with any patient population, we need to give an individualized risk assessment and use shared decision-making to listen to our patients and help determine what's best for them. I want to thank you for your attention. I apologize again for being later than anticipated. I'm happy to answer questions, and I realize it's the top of the hour, so I'm also happy to answer questions by email.
Thank you so much, Dr. Connors, for this really informative and interesting talk. I think we'll take the time to answer the questions in the Q&A. If you have any questions, you can enter it in the Q&A box. So we already have some very interesting questions. First question from Dr. Carrier. Thank you very much for a great presentation, Jean. He wants to maybe discuss a case. So 38-year-old trans women with PE using OCP for approximately 10 months, treated with 6 months of oral anticoagulants. She has discontinued hormonal therapy, which was mostly used for hair quality. She has no HER2 criteria other than sex. Would you continue OAC for secondary prevention or stop? Many thanks for your insight.
No, thanks, Mark. That's a great question. And again, it brings up the individualized approach. Where do I start with that PE? So if she's going to continue hormonal therapy or wants to reinitiate it, then I would consider continuing oral anticoagulants. And I, in this situation, if she's not particularly obese and has no meds that are contraindicated for use of 10A inhibitors, I would use apixaban or rivaroxaban for secondary prophylaxis. It's great based on the HER2 criteria. We know she does not have much in the way of residual vein thrombosis, and I'm going to assume is not obese, because there are some patients who develop PE and their BMI is 40. And those are patients that I would continue indefinitely on anticoagulation if they've had a significant PE, no matter cisgender or transgender, in line with the European Society of Cardiology approach. So in this particular patient, if they have other risks, absolutely continue oral anticoagulation for secondary prevention. Again, I think if it was life-threatening, PE would continue. And certainly if they want to reinitiate hormonal therapy, if they get any benefits. If they can do without the hair, that's a different quality, that's a different story.
Okay, thank you very much. Question from Dr. Skeeth. Excellent talk. Thank you. It's often difficult to lower testosterone level doses for transgender men, even if their hemoglobin is too high, as the treatment target is different. So 2 questions. What hemoglobin reference range do you use, and what value is quote unquote too high? And second question, what is your practice if the hemoglobin remains very elevated? Would you consider aspirin or phlebotomy? This practice variation and question has come up at our center. Thank you.
Yeah, no, so Leslie, this is an excellent question. And I will tell you, my personal history with this, right? Because we, in the trans men that I've seen, or in older men who are using testosterone for low physiologic levels and feel they derive benefit, we do try to reduce the dose as much as possible. If that's not an option, and in cis men, it usually is a voluntary thing, and it's an option. So I deal a lot with patients with congenital cyanotic heart disease, and their hematocrits can go up to 60% because of their hypoxemic blood. And I once spoke with Frank Bunn, professor emeritus here at the Brigham, who is a world-renowned hemoglobin expert, in vitro hemoglobin. He actually identified hemoglobin A1C a gazillion years ago, and deals with met hemoglobins. And I said, Frank, how high is too high? He said, we really don't know. When we think we're all, for those of us who are hematologists, we always think of elevated hematocrit and hemoglobin in association with myeloproliferative disorders, particularly JAK2, which in and of themselves are prothrombotic. So my approach in this situation, I think the elevated hemoglobin itself may not be prothrombotic like we think of with JAK2. It's the hypertension aspects, it's the symptoms. I get referred cisgender patients who have elevated hematocrits above 55% with no associated known genetic risks. I do check for genetic risks such as, von Hippel-Lindau mutations, as well as JAK2 and others. There's a hereditary erythrocytosis panel that we can send in the United States. And in many of these patients, it comes back completely normal. So there's something, in those patients, and I bring them up because they're mostly older patients. We can't find any secondary sleep apnea or anything like, or renal disease. Their erythropoietin level is not high. And I do therapeutic phlebotomy in those patients. Again, part of it is based on age. The patients I'm discussing are over the age of 60. Part of it has to do with other cardiovascular risk factors. So depending on the age of your person, your trans woman patient with or trans man, sorry, looking at the wrong question. If they're not tolerating it, if their face is red, if their blood pressure is high, I would do therapeutic phlebotomy. And what you're doing there is basically making them iron deficient. But it is a question for which we don't have answers to. And so I think if their hematocrit is below 53%, I am not too concerned. It's when it gets above 55 or they have symptoms.
Great. Thank you so much for that answer. Another question from Dr. Green. You mentioned continuing anticoagulation indefinitely in trans women or on HRT with a history of VTE. Just to clarify, do you continue when they have an alternate provoking factor, example, a trans feminine patient on HRT who has a DVT after knee replacement? Would you continue indefinitely in that case?
No, and that's a great question. So thanks for bringing that up, because I'm going to assume this patient is in an older age group, but has been on hormonal therapy for a number of years and has a clear provoking factor. Of course, the no it's a conditional no based on, say, HER2 factors, residual vein thrombosis, post-thrombotic syndrome, and other risks that might increase the risk of recurrence, right? One of the questions that comes up that I alluded to is, what do you do about hormonal therapy around surgery, and should, if it's an estrogen, in a trans woman, should the estrogen be held? No one knows the answer to that. I counter with in young women, we usually do not ask them to stop combination oral contraceptives. So again, I think you need to address these issues individually. But in this patient, if it was a clear provoking factor and there's no other reasons to continue anticoagulation, I would be comfortable stopping.
Great. Thank you. And we'll answer one last question from Dr. Linkins. Excellent talk. Thank you. Do you have any concern when using testosterone supplementation in trans men with APLAs or prior VTE? The data for no significant risk in average patient looks good, but limited.
Yeah, again, you guys are throwing like the toughest questions at me for which we have not a lot of data. But what I will say in this situation for trans man, again, stressing that low physiologic range if you can achieve it. If they have known antiphospholipid syndrome, I will continue anticoagulation. If they have the presence of antibodies, that's a tricky situation that we're all dealing with. And I'm not sure that I would initiate anticoagulation to use hormonal therapy in the trans men. But I would monitor them carefully. And it's also a little age dependent, right? Because when you get those like 60, 65-year-old patients and they maybe have maybe a TIA. I just saw somebody like this last week. They had amaurosis fugax. Someone checked antiphospholipid antibodies. They were strongly IgM positive in both ELISA assays and had a positive clot-based assay, and they were put on warfarin. But there was no true thrombotic event that happened. And so I took that person off, even though they have positive antibodies. So I would use that same approach in trans men. If they have antiphospholipid antibodies and they've had a thrombotic event, I would use testosterone, but I would use concomitant anticoagulation. If they have a prior VTE, it depends on the situation surrounding the VTE, the severity of the VTE. Mark Carrier's favorite calf vein thrombosis is much less concerning than a PE. So there's no risk in, that data from cis men in the New England Journal over a year, the VTE risk was really not there. It was more concern for cardiovascular risk, although that's in older patients, but the older patients also have an increased VTE risk. So I'm much less concerned about thrombosis in trans men than trans women.
Great. Thank you so much, Dr. Connors, for this great presentation. Just a reminder to all participants to please complete the survey that will be sent to you after the seminar, and the recording will be available on the CanVector website. Stay tuned for our next webinar, which will be held in February. And Dr. Connors, thank you again so much for speaking with us today.
Yeah, no, thank you for your patience. I'm so glad Mark had my phone number. I had my head buried in something, and I don't know why I thought it was noon. So thank you, Camille. And thank everyone. And if you want to distribute my PDF, feel free.
Perfect. Thank you very much, everyone. Have a nice afternoon.
All right. Take care. Thank you. Bye-bye.